Hey everyone, so in this video we're going to discuss what it means if you or your client experiences knee pain during hamstring bridges or any kind of activity designed to concentrate load through the hamstrings. Okay, oftentimes if we're trying to concentrate load through the hamstrings, sometimes the client will experience pain around the knee or they may experience pain down the anterior shin. It's something that we see not very commonly, but we do see it across a couple of cases in clinic, particularly if we're dealing with the clients with a current experience of pain, but also with a history of injuries across the lower limb. Okay, so we're going to discuss this within the context of a case scenario. Client with a current experience of low back pain, but with a history of knee issues. Okay, so there may be some limitation in how well the muscular tissues and the joint segments behave and handle forces across the lower limb that may be contributing to the current experience of low back pain. Okay, we're not going to get into too much detail into the subjective assessment and objective assessment, but we're just going to give some context to why this may be important. So let's say we look at the client's spinal flexion. We have the client reach down to touch her toes, and we see this concentration of movement at the pelvis very early on. So we see this flexion of the pelvis very early on. And when the pelvis flexes very early on, typically you'll see the spine remain relatively straight. So it looks like more of a hinge strategy. That's a fine strategy to use, as long as it's not the only strategy that we use, as long as we have the capacity to reach down and actually flex our spine. Okay, because if you're looking at someone flex their spine or try to flex their spine, and you just see a lot of movements early on at the pelvis via flexion or an anterior tilt, then that's not spinal flexion. That's just more pelvic flexion. Okay, if we want to flex our spine during the toe touch, we need the pelvis to be delayed in its flexion. So we need the pelvis to be relatively extended to the lumbar spine, so that the spine can actually flex early on, and then the pelvis comes along into flexion with a flex spine. If we flex very quickly to the pelvis, then it's just more of a hinge, and we're not distributing that flexion across the spinal extensors. Okay, that's an important consideration to have when you're looking at spinal flexion. Not just can they touch their toes, but what kind of strategy are they using to touch their toes. Okay, now let's say we also identify that the client has a limitation or an inability to manage loads or forces or stress or pressure very well through the hamstrings. Okay, now that may make sense if we consider that the client struggles to maintain more of an extended pelvis as they flex the spine. The proximal hamstrings are going to be very important there to allow for that pelvis to be delayed in its flexion movement. Okay, so let's say we choose a strategy like this. Okay, so we choose more of an isometric hold or static hold where we get the client into a supine position like this. So we'll bring this up into the full screen. We get the femur into more of a flexed position here, because when the femur is more flexed, it'll afford a greater capacity for the pelvis to extend. If we have that femur too extended early on, it becomes a little bit more challenging to extend the pelvis. So we want to make it easier for the client early on to both extend the pelvis, but also to get some load into the hamstrings. So we have the client drive low through the heel, scoop the pelvis up, so we're getting extension of the pelvis, flexion of the lumbar spine, and have the client continue to drive that load down through the heel. But let's say as they carry out this static hold, they experience some pain around the anterior knee or down through the front of the shin. Now, we have some options here. We are considering that we've identified that the hamstring has an inability to manage forces. Okay, so if the client experiences pain in the anterior knee, when the focus is on this tibial flexion biased hamstring bridge, because when we're looking at hamstring activity, we typically have the segments that are involved are typically tibial flexion to drive load through the distal hamstring and femoral extension to drive load through the proximal hamstring. Okay, and there is going to be a pelvic component to that as well. If we get some load via tibial flexion here, because with this femur flex as it is and knee flex as it is, or the tibia flex as it is, it's going to concentrate that load through the distal hamstrings. If the client is unable, or if the distal hamstrings are not conditioned to manage those forces, then perhaps we can experience some sensitivity around that local joint region around the knee, or you may experience that pain down the front of the shin, which we see in clients. That does not mean that we choose not to distribute load or concentrate load through the distal hamstring. It just means that we need to reorganize or modify our intervention to still allow us to get some load into the distal hamstring, but not to concentrate that load into the distal hamstring. Okay, so what kind of strategies can we use here? Okay, so key thing to consider here is that this is a more femoral flexion position with more of a tibial flexion bias to get some load into the distal hamstring, but we're still trying to allow the client to experience some load into the hamstrings while we get some extension into the pelvis, because we're coupling this with other objective assessments that we've used. Okay. So again, the client has pain around the anterior knee here. What do? We could bring the other leg down and just share some load into the opposing limb. Okay. But let's say that wasn't enough for the client to really experience that load into the hamstrings. Okay, it made it easier, but we still weren't getting that load to the hamstrings to allow the client to really sense that force moving through the hamstrings. We also need to consider in some situations that the distal hamstrings may already be experiencing a lot of load, so we don't want to put too much load through it. But again, like I said, during the objective assessment, through your assessment, you identified that distal hamstrings, the hamstrings as a whole, weren't able to manage force as well. Okay, it may just be a case that they're just not conditioned to manage forces, and we're seeing that sensitivity as more of a protective response. One option that we can use here is we can distribute some of that force production, that force generation into other muscular tissues and other joint segments. Okay, so we can distribute some force, still biasing more of a static hold and isometric strategy here, but we can distribute some of that force into ankle extension, or plantar flexion, and femoral extension. Okay, but what I want you to consider here is that we're still keeping the foot segment higher than the pelvis. This still makes it a little easier to extend the pelvis. So we're still trying to target that limitation via pelvic extension, but we're just making it easier for the client to experience that load through the hamstrings by sharing that workload, distributing that workload across the lower limb. Now, just before we get into this, one of the key reasons why we put so much emphasis on the low capacity of the biarticular tissues with any kind of musculoskeletal condition or pain experience or movement limitation is because the biarticular tissues that run across these non-segmented structures, like the femur, like the tibia, fibula, the ulnar radius, the humerus, for example, are very important because they don't have that segmentation in those joint segments to share that motion or to dampen those forces across that region. Not like the hand, the foot, or the spinal region that has that segmentation that allows for distribution of motion to dampen forces across it. That's what makes the biarticular tissues across the limbs very important for us. So you're looking at the design features of the anatomical, the mechanical apparatus that we all possess. We all have biarticular tissues across our limbs, but can we exploit their behavior? Because they're there for a reason. Okay, there's a reason why we have a monoarticular tissue in the glute max, and we have more longer tissues, biarticular tissues across the femoral segment, the tibia and fibular segments. Okay. They're very important for load sharing. So that's why we put so much emphasis on them. But early on, we may have to really change how we're putting load through different parts of the biarticular tissues before we increase the speed or increase the challenge across rehabilitation. So I just wanted to point that out there. So we're still looking at how we can get some load into the distal hamstrings, but not concentrate too much load into the distal hamstrings, because the distal hamstrings aren't conditioned to manage that much load just yet. It doesn't mean that we don't load them. Okay, so we get the shoes on because we put the shoes on because we want the foot to be angled on the edge of the bench here. So we're not going for a heel focus strategy now. We're getting the metatarsal heads engaged. It's just easier to do this with the shoes on. It's an easier platform for the client to use. We have a little bit of plantar flexion of the ankle. And what we're doing then is we're driving that load through the metatarsal heads and then again scooping that pelvis up into pelvic extension and lumbar flexion. And typically what clients will note with this is that they'll feel a much greater sense of force moving through the belly of the hamstring, okay, instead of just the distal hamstring, okay. And typically they'll note that reduces that sensation of discomfort or that experience of pain through the anterior knee and down the shin, because now we're distributing that workload via ankle extension. So getting some load through the distal plantar flexors. We're getting some load through the proximal plantar flexors through the gastroc, because that's going to aid in knee flexion or tibial flexion. And we're getting some load into femoral extension as well, because this bridging strategy here is really a combination of ankle extension, foot extension, so an extension of the foot segment, tibial flexion, and femoral extension. Okay, we're just using this as a strategy, still a static hold, to still concentrate or still get some load into the distal hamstrings, but not too much load early on, and to distribute that force across the a broader surface area across the lower limb. Okay. Now we can add some dynamic challenges with this as well, but typically we'll start with more isometric holds. Okay. But we'll discuss why we might keep the foot segment higher than the pelvis to make it easier to extend the pelvis. Okay. So this type of thought process in rehab is very important because we will oftentimes have clients with poor capacity to manage forces in certain muscular tissues. But when you begin to put load into those muscular tissues, they may experience sensitivity. It doesn't mean you don't load them. It means you have to step back and consider, okay, well, they lack that conditioning to manage forces. So instead of just throwing lots of load at them, we may need to gradually expose them to load. How do we gradually expose them to load? There's many options, but distributing that force production or force generation across more muscular tissues and other joint moments via foot segmental extension here, tibial flexion, femoral extension is one strategy. So it's looking at within limb compensation or intra-limb compensation instead of just using the other limb to come down, which would be more inter-limb compensation to help distribute force into the other limb. We're trying to distribute force across other muscular tissues within the same limb. Okay. So again, like I said, really important concept to consider during rehab, but a feature that we see not very commonly, but we do see it across clients that have a history of injuries around the knee, for example, or around the ankle, or around the hip. And when you're getting low into the hamstrings, you may see this if they have a inability to manage those forces through the distal hamstrings. So we need to consider how we can manipulate the activity or modify the intervention to still get load into that region, but not too much load. Okay, but we can consider this concept across the entire anatomy and across many different case presentations, many different pain experiences or movement limitations. Okay, so if you made it this far, thanks so much for listening, and we'll chat to you again soon.